Good evening, everyone. Am I audible?
Yes, you are.
Yes, Gayatri.
Yes. Good evening, everyone, and welcome back to the second day of this insightful webinar on dignity in care, the human side of medicine, hosted by Pallium India. Day before yesterday, we have explored the foundational aspects of dignity in care, and today we continue our journey with an enriching lineup of discussions and reflections. Welcome back, Dr. Harvey Max Chochinov, for today's webinar on dignity in care, part 2. I'm handing over the session to Dr. Sunil Kumar, and it's over to you, sir.
Thank you, Gayatri. Good evening, everybody. Good morning to Dr. Harvey, and many of you are in different time zones. So, good morning, good afternoon, and good evening. Um, so, welcome, and I know all of you would be looking forward for this second session on dignity in care. And as I already introduced Dr. Harvey in the previous session, but I would be introducing him briefly. So, Dr. Harvey Max Chochinov, um, who is a well known psychiatrist, and he has been practicing dignity therapy, and he is the founder of dignity therapy. And he is very well known in that aspect. And with his contributions in psychosocial aspects, he has contributed a lot to palliative care too. Um, so recently, he has published a book, which is Dignity in Care: The Human Side of Medicine, which is available for India at a reduced rate. And I would encourage all of you to buy that book and read it. And with this brief introduction, uh, I think I would hand over the session to Dr. Harvey Max Chochinov. But Dr. Chochinov will be talking to you for about 45 minutes. And then we have Dr. Rajagopal leading a session. It's a discussion mainly on dignity and healthcare within an Indian context. So that will be from 7:45 to 8 p.m., followed by reflections and question answers. So first, Dr. Harvey, it's over to you.
Wonderful. Thank you, Sunil, and thank you for the kind introduction. And again, I'm feeling really very honored that you and Dr. Raj and all of the people at Pallium India have made this forum available to me to share some of my thoughts and teachings about the work that I've been engaged in for many decades. Okay, I am just going to share my screen. And are people able to see that?
Yes, yes.
Perfect. Okay, so just if you're wondering if you're in the right place, this is Dignity and Care, the Human Side of Medicine webinar, part 2. Um, As I said last time, my only request for all of you attending is that you try and spread the teachings that you hear here as far and as wide as possible. That would be my only request. Um, I think we have some people online who may not have been here last time. And for those of you who were, just a few moments to kind of give you a brief overview of what we talked about last time. I began by showing you this poignant painting by the Canadian artist Robert Pope. And the reason that I chose this image is because we see someone who is precariously at the water's edge, floating at the verge, perhaps, of being drawn under. And our task in healthcare is to understand what are the things that keep people buoyant, metaphorically? What are the things that metaphorically threaten to pull them under? And those things are beyond the domain of the physical. They include the psychological, the existential, and the spiritual. And in order for us to be healers, we need to be attentive to all of those domains of influence on patient experience. The other slide that I'll show you that I referred to last time was what I described as this epiphany during the course of my research. And that is when we were exploring what are the things that influence dignity for patients living with life-threatening and life-limiting illness, this notion of how people perceive themselves to be seen, appearance, the esteem in which they feel they are held, more so than anything, was what upheld or threatened to undermine a patient's sense of dignity. And this image illustrates it so beautifully. This is an image that was created by the Dutch graphic artist M.C. Escher. And you see a self-portrait, a man in his apartment, surrounded by his books, his photographs, his paintings, his belongings. In other words, the reflection, metaphorically, in the eye of the healthcare provider is one that is affirming of personhood. And of course, the great challenge and the reason that we need to be invoking ideas like dignity is that when people enter into healthcare, they are potentially battling the issue of patienthood overshadowing personhood, which is why we need to think about our lens, the way we see, the way we perceive, the way we appreciate or not patients who come into our care. Do they experience themselves as just another patient? Is the reflection in our eye one that just includes a differential diagnosis, a problem checklist? Or are we able to do things by what we say, by what we do, that acknowledge the essence of who they are, not just on the basis of what they have, but the person that they are, the person they've tried to be, the person that they've always been. So that's my quick overview of what we did last time, and of course in far more detail than that. So in part two, let me kind of continue taking you on the dignity journey, so to speak. One of the early studies that we did, besides the ones that I introduced you to last time, was a study in which we set aside the numerical instruments that we had tried to devise to measure dignity and began doing qualitative work, which really means sitting down with patients at the bedside and exploring with them in in-depth interviews and conversations. What does dignity mean at this time in your life? When does it work? When doesn't it work? Give us examples. Tell us about the various things that can influence dignity. This eventually yielded what we called a model of dignity in the terminally ill. And the reason I have the paper juxtaposed with a map is because in many ways, what the model provides you is a map. I mean, up until this point in time, as I pointed out last time, you would see dignity cited in the literature frequently, but really as a quite nebulous, politicized term to support whatever position you happen to hold. And even though people may give lip service to the idea of providing dignity-conserving care, unless you drill down into understanding, well, what do we mean by dignity? They're simply words. They're words that might appear in a position statement or in a vision statement, but they don't have any real practical application unless we can operationalize what we mean by providing dignity-conserving care. And so let me show you what the map that we came up with looks like. So it's not your typical looking map, but this is the model of dignity in the terminally ill. What you can see is it contains several major themes, and beneath each of those themes, some sub-themes. So, and again, we don't have time to go into all of the detail, and all of the references, I think, should be noted in your handout. And if not, simply go to PubMed. They're all in the public domain. All of them are open access. So what you see is that in order to be attentive to dignity, at least in a large perspective, or from a broad perspective, you need to be attentive to what we call illness-related concerns. In other words, there are things that being sick, being ill, having a disease in and of itself can do to the body, to the person, that are going to have an influence on dignity. And so what do I mean by that? Well, being ill can affect your level of dependency. It can affect your cognitive acuity or functional capacity, and it can affect your symptom distress, whether that be in the psychological or in the physical domain. By the way, what's interesting is that although many of those things you may think of as being as fairly typical in terms of palliative care approaches, when you look at the dignity map, there begin to be some things that you might not necessarily have predicted. For example, medical uncertainty, death anxiety. For patients who are approaching end of life, there are instances when not knowing what to expect, fears about what will come, can be a source of anxiety and a source of undermining sense of dignity. At the far end, you see the social dignity inventory. In other words, think of it, there are things that can happen to the body. There are things that can happen outside of the individual. So in other words, one's social environment, which includes things like respect for privacy, counterbalanced by adequate support, care tenor. I talked about this last time in terms of therapeutic presence. It's not about what you are saying or doing necessarily. It is the tone of your care. And it's a tone based on your demeanor that can either extend the message that you are there and fully available, or you're disinterested or distracted. And then finally, the middle category is something we call the dignity conserving repertoire, which really has to do with the psychological, the spiritual, the existential landscape, if you will. And it includes things like, do I still feel like me? A continued sense of self. Are there things that I still place importance in? Hope, we know, for patients who are approaching end of life becomes uncoupled from expectation of time and really resides within the domain of meaning and purpose. And also, you will notice generativity. This is a term we borrowed from the developmental psychologist Erik Erikson. And what it refers to, and what patients told us, is that for some of them, assault on dignity means that there won't have been a ripple effect as a result of them having been alive. You know, that will there be some lasting influence? Will their lives have made a difference to people who will then be left behind to mourn their passing? And things like, you know, living in the moment, maintaining a sense of normalcy and spiritual comfort. Again, that's a very quick overview of the dignity model, or map, if you will, and the details are available in the articles for those who are interested. What's important is that this isn't, none of these are hierarchical, which means that one isn't necessarily more important than the other, and they also apply differently across individuals. So as we know, for some patients, you know, the crux of maintaining dignity is good symptom management, being made comfortable. And once that's achieved, in their mind, dignity has been sustained or has been bolstered. And for others, it may be very much about generativity, or it may be very much about a spiritual journey, or making peace with one's maker, or perceptions and conceptions of one's maker, or it can be a combination thereof. So the importance of the map then is it begins to operationalize how we can invoke dignity conserving care. I mean, to this day, people will ask me, well, what do you mean by dignity? And immediately my mind goes to this. Dignity refers to this umbrella term that subsumes these various different entities that can either support or undermine sense of dignity. So how can we use that to help guide our work? Well, one of the things we did is we used that model to create what I have coined the patient dignity inventory. And for those of you who are familiar with the ESAS, the Edmonton Symptom Assessment Scale, this is sort of like the ESAS, but it expands on it in that it includes items that cover not only the physical, along with some psychological, but the physical, the psychological, the psychosocial, the spiritual, or existential. So if you look at the PDI, each of these items are based on a theme or sub-theme from the model of dignity in the terminally ill. Now, some of them reside very much in the physical realm, not being able to attend to bodily functions or experiencing physically distressing symptoms, to things that are much more nuanced, and you wouldn't necessarily think about asking patients in a routinized way, feeling that how I look to others has significantly changed, or number 11, feeling like I am no longer who I was. And I can tell you, and I'll be showing you data in a moment, that this turns out to be a profound existential issue for our patients. And the lovely thing about an instrument like this is that, first of all, it is easily administered. It's free. It's in the public domain. Again, I believe there are multiple translations. There are cross-cultural validations of the patient dignity inventory. And it's being used now as kind of a gold standard measure of dignity-related distress, both within and beyond palliative care. So the other thing that it does is that it allows you to give the patients language that might help them describe what is happening to them. So oftentimes, suffering, loss of dignity, angst can feel nebulous, both to the observer and to the person experiencing it, until you begin to drill down to find out, well, what is the essence of your suffering? Where does that come from? Some people have said, well, is there a danger of, using these tools and it's somehow replacing conversations? And I would say there is no such danger whatsoever, knowing that this is meant to prompt conversations. This is meant as a screening tool to give you, the clinician, a sense of where is it that your patient is struggling. So going back to the metaphor of a map and thinking about geography, it's very helpful to have a tool like a telescope, a microscope, something that helps you see things on the horizon that you wouldn't necessarily have been able to see. So using this new tool, the patient dignity inventory, it allows us then to look at what I have described as the landscape of distress in the terminally ill. So if we pick up this new instrument, suddenly we can now see things that may not have been as clearly visible. And what do I mean by that? Well, this is a study that we did. There were several hundred patients near end of life who we administered the PDI. And what did we find out? We found out that this is the prevalence of dignity-related distress within a cohort of patients with life-threatening, life-limiting illness receiving palliative care. And you can see, as you might have predicted, not being able to carry out usual routines or feeling physical distress, not being able to carry out things that feel important to you. But look at what comes next. No longer feeling like who I was. This sense of personhood. And last time, for those of you who attended, you remember me talking about this notion of fractured personhood. And so it is the case that in our patients, besides concerns about pain, besides concerns about their ability to carry out their usual role and function, one of the critical existential issues that people can confront and feel challenged with is, am I still me? And the truth is that illness takes away, and it causes people to feel diminished. It can take away capacity and vitality, autonomy. But when it starts to take away things that feel quintessentially part of what defines who we are, this is when people suffer. And this is when people will endorse the fact that they no longer feel like the person that they once were. And this is in descending order. So you can see that many of these things are less highly endorsed, but nevertheless appear on the radar. I mean, depression is about 20-25%, very consistent with other findings. And, isn't it interesting? Because we routinely ask about the physical. We will routinely, oftentimes, even ask about the psychological, what's your mood like? How often, when's the last time you asked your patient, do you still feel like you? Do you still feel like the person you once were? And as it turns out, that is both prominent and significant. We put this new tool into the hands of nearly 100 psychosocial clinicians across Canada. And we essentially said to them, try it out, give it a test run, see what you can learn by applying this to your patients who in many instances were dealing with advanced or life-limiting cancers. And what did we find out? In nearly 80% of instances, these clinicians learned something about their clients that they didn't previously know. And in, again, nearly 80% of instances, they said that administering this tool and the information that they were able to access by way of it actually assisted them with the care that they provided. Now, this is the first time that I've talked about this in public, in that this is not a published study, which is why I have not included any data on this slide. But I made mention of it last time. I have a wonderful doctoral student, Selena Perzada, and she is doing this very interesting study where we are trying to interview patients who have requested or been approved for medical assistance in dying, and simply trying to find out what are the motivations, what are the things that move you towards a decision of no longer wanting to be alive. And again, the conversations are riveting. They're really fascinating. And I shared an anecdote regarding one of those interviews last time. We also have applied the patient dignity inventory. So this is data pertaining to a cohort of patients. This is all preliminary data. So this is just about 20 patients who've completed the protocol thus far. And this is in descending order, the way in which people respond to the PDI. And you can see, and again, this is very consistent with data that we're seeing coming out of Health Canada and that reports on medical assistance in dying. All of these distressing symptoms, depression, anxiety, not being able to think clearly, not having control, nearly all of them are endorsed at 100%. Look what comes next. Feeling like I am no longer who I was. As I recall, it was greater than 95% of patients in this cohort of people who have all requested or are waiting for medical assistance in dying, endorsed that I no longer feel like the person I once was. So an extraordinary existential issue facing patients and can sometimes even undermine a wish to go on living. Okay. Let me now segue to dignity therapy. And just to give you the connection, dignity therapy and the idea of dignity therapy is entirely based on that model of dignity in the terminally ill that I shared with you. So it's not something that came, out of thin air. It is something that was based on the model. And we looked at the model and said, okay, if we were to try and devise a psychotherapeutic intervention based on what this model tells us about dignity, what would the components of that be? So we looked at various different elements. First off, we looked at generativity. We decided, well, if generativity is important, it means that whatever happens in this psychological intervention, there needs to be something lasting, something tangible, and something that could even be transcendent of that person's death, that could continue to have a ripple effect, if you will, or create a ripple effect, so that that individual's words, experiences, advice, wisdom would extend beyond the grave, so to speak. And so we said, well, I think that means that this talking therapy needs to be recorded. It needs to be transcribed. The transcription, whatever we do with it in terms of editing, needs to be returned to the family or to the patient, I should say, so they can then share it with the people that will eventually grieve their passing. So that explains the form of dignity therapy, if you will. Okay, we got that much down. Then we said to ourselves, well, okay, we know this is a psychotherapeutic intervention, but what are we supposed to talk about with people? What would be important? And that's where we looked at the dignity conserving repertoire and all of these things that had to do with personhood. Say, well, I guess we should be talking about kind of sense of self, or the things that were important to them, the things that they took pride in or felt that somehow defined them. Maintaining hope. Again, it's not maintaining expectations for a prolonged future, because in the terminally ill, hope becomes uncoupled from expectations of future and begins to reside within the domain of meaning and purpose. So talking about things that are meaningful and purposeful, roles that were important or are important, and aftermath concerns. This was in the social dignity inventory. This is the concern that people have in terms of the burden that their death will place on those they leave behind. And so could dignity therapy provide a way of people being able to safeguard, if you will, the well-being of those that they care for? So we knew that those items are going to form the content of dignity therapy. So we have generativity informing the form. We have all of these issues informing the content, and then the tone, social support, care tenor, non-judgmental, affirmation, a word that I used last time, and I use a word that I use again. If we can provide an affirming reflection in the eye of the healthcare provider, we can safeguard against personhood being eclipsed by patienthood. So those were all of the elements that we said need to be included in what we coined dignity therapy. Went on from there to say, well, to write a book on dignity therapy, final words for final days, and began doing a series of studies. And I'll tell you about some of the data just in a moment or two. But to make this tangible, I think it's a good idea for me to tell you about the first patient who we kind of test ran this on. He was a man who was in his late 60s, early 70s, end-stage colorectal cancer. He had gone on a hunger strike, or that's how it was reported to me by his medical oncologist. And he had just stopped eating, was not interested in continuing to live. And so his medical oncologist, a wonderful gentleman, a colleague to this very day, Dr. Paul Danig, referred him to me, admitted him to the ward. And, I think the fantasy, the hope was that I might be able to diagnose a depression, and that I would sprinkle Prozac on everything and everyone would walk away feeling happier. Well, the story did not unfold in that way. When I walked into his room, and this was at St. Boniface Hospital, the first thing he said to me is, if we were in a European country where I could press the button now, I would. And you know exactly what button he was referring to. He was saying that if euthanasia and assisted suicide was an option, I would avail myself of that option. So I thought, well, I've got my work cut out for me. Sat down, did a standard psychiatric diagnostic evaluation. And indeed, he had a good range of affect. He was engaged, he was affable. There was no paucity of thought. There wasn't kind of self-deprecatory thinking or cognitive distortions that you sometimes see in depression. He was simply saying, my body's just not cooperating with me. There's lots of things I would love to do, but it just ain't working. So what's the point? And so I said, well, I don't think that, there's any psychiatric condition per se that I can provide you assistance with, but we are just trying to develop something that we have coined. I think we were calling it dignity psychotherapy. We since shortened that to dignity therapy. And I explained it to him. I said, how would you feel about me coming back soon? Because there's an ethos of immediacy. Your words matter. This matters. So, you don't want to make it protracted over a long period of time. How would you feel about me coming back and leading you through a discussion in which you could, share some reflections on your life, the things that matter, the words that you would want to share with your family, and so on? He was immediately intrigued. As I recall, I think he was a social worker at one time and worked up in northern Manitoba. So he was immediately intrigued and said, yes, that sounds like something I'd be interested in doing. And I said, okay, I'll be back in a day or two as soon as, we can arrange this. And as I was leaving his room, I said, by the way, if you could press that button now, would you? And he sort of sheepishly looked at me and said, well, no, I'd like to do this first. And I remember running down to the clinic to speak to Paul and say, Paul, it's like palliative care penicillin. And Paul said, Harvey, it's one patient, it's one experience. You need to do the studies. And of course, that took up the next 20 years of my life. Not entirely, but a good portion of my academic work was spent looking at this, along with other issues that we've examined. So I came back in a day or two, set up the tape recorder. He wasn't feeling particularly well, but when he saw the recorder, he said, let's try this. And for the next hour, with not very much prompting, he told me the story of his life, not in its entirety, of course. I mean, there's 70 years to cover, but these critical vignettes, where he was born, the story of his immigration and the hardships of that immigration to Canada, the birth of his children, the tragic death of one of his children, even the messages that he wanted to leave to his now elderly wife and his hopes for her in the life that she would leave after he died. And it was lovely. He was a well-spoken gentleman. We were able to transcribe and edit the document within a few days. By the time I came back, he was too weak to actually take the document from my hand. But his wife, who was sitting at the bedside, and she knew all about this, turned to me as she took the document and she said, "This will be a blessing to our family." So that gives you a sense of dignity therapy, what it does, how it works. And for those of you who were here last time, if you had time to watch Bruno's story, you had exposure to what was a really lovely and poignant case of how this gentleman was able to use dignity therapy to really turn around the way he was feeling in terms of his illness and outlook. So let me briefly describe, and again, this is an introduction. I mean, when we teach dignity therapy and have done so in the past, I mean, this is something that takes place over the course of 2.5 days. So first of all, though, we identify eligible patients. Who is eligible to do dignity therapy? At one time, when we first began doing this, I know that, the research nurse I worked with and even the people in the ward would say, "Oh, I've got somebody for you. I think they've got really great stories." And I would say, you know what? That's not the criterion, because the truth is everybody's story is great. And the thing that makes it great, it is their story. So the thing that makes a person eligible, though, is being in what I call a place of existential readiness. they're in a place in their life where they feel reflecting on where they've been up until now, sharing their thoughts, sharing their insights, feels emotionally, spiritually meaningful. And that can have application certainly in palliative care. But as you'll hear in a moment, it also can have applications in other areas and in other times of life. Um, so the other thing is that you need somebody who has at least the cognitive wherewithal to be able to respond to some questions in a meaningful way, and a life expectancy that will at least see them through the course of the intervention, so that you're not starting something and then losing patients because they deteriorate and can no longer take part. Um, Explain fully then dignity therapy. And there is no merit in the element of surprise. I will tell people about it. It's in its entirety. I will even share the question framework, and I do that as a matter of routine. I know that during COVID, for some reason, I did more dignity therapy than I've ever done before or since. And I would speak to people on Zoom. I would email the question framework to them and explain it to them, ask if there was any questions. The reason that I send the question framework again is you're wanting people to think about it. You don't need to have people prepare their answers or write their answers. I tell people that this can be very spontaneous, but priming the pump, getting people to think a little bit about how they might want to respond to some of these questions. Next, obtaining a framing interview. What this means is it's a separate interview in which you basically want to find out, how the person would like to be addressed, who the key players are in their life, so you know who this is being done for, and what their goals are. Now, that may sound sort of self-evident, but it's very helpful to know. For example, I'll be telling you about a case of a woman whose goal was to produce something that would help her children remember her, because she knew that she wasn't going to survive her illness long enough to be remembered. Knowing your goal, knowing where your destination is, will help you get there. Next, and the framing interview is that comes later. Sorry. Next, arrange a date. Ethos of immediacy. You want to do this and deliver a message by framing it, or by having this being done relatively soon, because first of all, time is not always on your side, especially if somebody is critically ill. And as well, you want to give the message that you matter and your words matter. Then set up a session to do dignity therapy, and that usually I give myself an hour. Occasionally it doesn't take as long. Rarely does it take more than that, especially for someone who's critically ill. An hour is kind of the sweet spot that we've discovered is workable. Immediately after that, there's the edit, the transcription and the editing of the protocol. One of the things that happened over time is with voice recognition, many of the programs are able to give you an automated document that is transcribed. There's a protocol for the editing, and then there's a follow-up session in which the document is read. If the patient wishes, it can be read in its entirety to them. I have found during COVID, there were many instances where people just wanted it sent to them. They would read it on their own, and then we would have a final session in which we would make any corrections and present them the generativity document. So that is how dignity therapy in essence works. In your handout, you have a copy of the dignity question protocol. I underscore, this is not meant to be formulaic. This is meant to inform a conversation that should feel very routine. But it often happens that patients will say, look, I trust you. I'm not sure what I need said for this, so help guide me. You notice the initial parts of the protocol are sort of the biographical. And again, it's not telling the entirety of their story. It is asking them the vignettes, the things that they would want remembered. And I spend, and there's a lot of time management that goes on here. I spend maybe about half of the interview allowing myself to focus on some of these things that are biographical, memories that are important, things that roles that were important, accomplishments that were meaningful to them. And the second half, which is more emotionally evocative, has to do with, are there things that you would like to say to the people you care about? Even individually, are there hopes or dreams for your children, for your spouse, for your parents, friends? Are there lessons that you've learned that you would like to articulate and pass along, or even instructions that you would like to share? So again, that gives you the essence about dignity therapy. Just a few tiny comments on what I'll call the nuances. What dignity therapy is and is not. Dignity therapy is not a insight-oriented psychotherapy. So this is not an opportunity in a recorded session to, come to terms with some conflict that you have had and are trying to work through. Not that that work is unimportant, but it's just not the kind of work that needs to be recorded, transcribed, and shared with generations to come. What dignity therapy is about is facilitating somebody being able to tell their story. And again, that story is vignettes and it's of wisdom. So it's not just biographical, it's the things that they would want passed along. I talk about in my book, good, sad, and ugly stories. What this refers to is that, some of the things people tell you in dignity therapy, the good things are, they loved me, I loved them. It's been a wonderful life. I'm grateful. I mean, that would be, kind of in a very superficial way, what a good story is about. Dignity therapy is not exclusively about those good stories. It's the story that needs to be told. And there are sad stories that people need to tell. Sometimes, and I give an example in my book of a gentleman who really squandered relationships and did this, he said, not so that my grandsons will know me and follow my way, but it's so that my grandsons will know me and know to follow a different path. And then finally, what I referred to in my book is ugly stories. And it may not be the best term. And I think I've had some change in thinking over the years as to how I would label it, but it is the story that could have the potential for harmful impact on the recipients. And one of the most delicate issues that we deal with in dignity therapy training is in the moment to recognize and to deal with and help the patient deal with content that could potentially be harmful to the recipient if we didn't have this conversation during the course of it to say, are those the words that you would want to leave with your loved one? And to consider the implications and the lasting effect that that may have. I use what I call a photograph metaphor. So oftentimes a way of helping people delve into this idea of not creating a fulsome biography is to say, if you and I were sitting at a photograph album of your life, help me bring attention to the photographs you would like me to see, the ones that you think are important to be known, and have them describe those. And it works very, very well. Be cautious about pseudo-meaningful conversations. In other words, you're an empathic person. You're giving people an opportunity to talk about things. One of the rabbit holes is asking about illness. You can spend a long time somebody talking about their illness, and at the end of it, they will have felt understood. That you listened to them talking about their anguish and their journey. But the problem is that none of that has anything to do with generativity, which means that you need to understand the destination, you need to understand the protocol, and you need to be willing to impose structure so that you're not there trying to construct a complete biography, but you're trying to create a meaningful generativity document. I am almost out of time. I'll take maybe a couple of extra minutes just to say there have been lots of studies on dignity therapy. We did studies that showed high satisfaction. We've done studies on families that show high satisfaction. In fact, that this is as meaningful as anything else that they've done that was done on behalf of their dying loved one, and that it is a bereavement intervention and has given comfort during their time of grief. We've done randomized control trials. I think I'll skip this one. Most recently, there was a lovely trial that came out of the University of Florida, a randomized control trial of dignity therapy done in an oncology setting, administered by chaplains and oncology nurses, again showing significant effects on dignity impact, control versus non-controls. There have been over 100 papers. There have been over 12 systematic reviews, all of them affirming the efficacy of dignity therapy. And this is just a collage I made of the reviews. Dignity therapy is beginning to be applied in different circumstances. This was a study of dignity therapy amongst people who found themselves in prisons, incarcerated, and were dying there. Dignity therapy has been done in patients with serious mental illness, again, another condition where personhood is under assault. Dignity therapy has been done in patients with cognitive deterioration, using patients and family members to co-construct a document. And dignity therapy also seems to be finding its way into the lay press, and these are things that you can find online. This was a lovely article that was published in the Washington Post on dignity therapy, and this was an article that came out in Australia. For those of you who watch Bruno's story, you might recognize this gentleman as being one of the individuals who has been spearheading dignity therapy there. Let me take one more minute because I know Dr. Raj has some wonderful insights he would like to share with us, giving us the Indian perspective. Let's bring this back to the bedside. I mentioned there was a woman that I saw recently, well, about a year ago now. She was young, in a relatively new marriage, young child, and dying of metastatic breast cancer. She heard about dignity therapy and immediately knew that this was the thing she needed to do. Her agenda, we did the framing interview, is to say, my children are going to live far longer than I will, and I am not going to live long enough for them to remember me. And that's why she was invested in doing dignity therapy. Her session was brilliant. She talked about critical milestones in her life that helped shape her, worldview and her outlook, the things that she felt were important. She left some wisdom around particular issues that she felt her children might benefit from, the importance of nature, the importance of learning, the importance of connections. She thanked her family for bringing her into the world. She thanked her friends. She also gave explicit permission to her husband to remarry, with the proviso that whoever he would choose would love her children the way a mother is meant to love a child. And so she shared with me the fact that dignity therapy helped her prepare for death, and dignity therapy helped her prepare her children for life. That, in a very brief way, is the essence of dignity therapy. It's capturing this story in the service of generativity so that it can have a ripple effect across time. Again, this is how you contact me. You can follow me on social media, which is only used to talk about professional issues that I would like to make known or available. And again, I'm grateful to Oxford having put out this low-cost version of my book, Dignity in Care, available to colleagues in India, Bangladesh, and beyond. With that, I will turn the floor over to Dr. Raj, after which I'll look forward to hearing some reflections and time for questions and answers. Thanks so much.
Thank you, Dr. Harvey. I think we can move on to the session by Dr. Rajagopal. So he'll be talking about dignity in care in an Indian context. Sir, for those who don't know about Dr. Rajagopal, he's the emeritus chairman of Pallium India, and he's the founder of Pallium India. And he has won a lot of awards, including Padma State. Um, and yeah, I'm not explaining more. It's all to you, sir.
Thank you, Sunil. Harvey, uh, what a treat. Thank you. How many hats do you wear? Clinician,
Well, I have very
teacher,
little hair, so I can fit many hats.
researcher, writer, but more than all that, an activist. Otherwise, much of the research would be lying in libraries. Thank you. Once I expressed a doubt to you whether you are really real. You seem to be okay. I'll truly believe it
it,
when I meet you in
it,
person.
it is mutual admiration. You have had an extraordinary career, and you have transformed India. You are the pioneer. You have transformed in palliative care in India, and have had a global influence, including, I understand, having been nominated for the Nobel Prize. So I am in the presence of greatness.
Thank you, thank you. Uh, what I'll try to do in the 15 minutes that I have will be it'll be a bit of a laundry list of various issues. It may not be one connecting with the other because I have picked up important points about what you talked about in the 2 days and also what you talk about in your book, uh, which would be particularly relevant to our country, possibly maybe with added relevance. Uh, Sunil, I hope I can share my screen, right?
Yes, yes.
Uh, I Sunil,
But, uh, um,
I
you,
wish
you, clicked
I
on,
had the sense to try this earlier.
you clicked on the Zoom. Just click on the, yeah, no, no, no.
But
That's on, yeah, just seeing the Zoom icon now.
no, am I to click on join?
And not join the slideshow.
Not Zoom. It's like
There's
yes,
there's a problem there.
web browser.
Okay,
Yeah, it is running in the web browser.
I won't. I mean, I broke a fundamental rule. To test things down like this early, this graphene thing, uh, I was not familiar with, and I did not expect this. I apologize. I will not waste time now. That's absurd. Try
So
to.
click on the
Click on the
slide
slideshow, sir.
slideshow.
Somebody was talking. Was it to me?
Yeah, yeah. So click on the slideshow option
I did.
on the
Yes,
top.
yes.
Yeah,
Yeah, it's okay.
yeah. Now it is okay. Yeah, that's all.
Yes, sir.
Or are you saying that you can see it now?
Yeah,
Yes,
yeah,
yes.
yeah.
Okay, thank you. Thanks for the help. Was it Mahesh? Thank you.
Okay.
Uh, I'll give you this list of a few things that I said I thought were very important, both from his talk and from his book. Uh, One was about valuing humility, and why is it particularly relevant to the our country? Is that unfortunately, as things happen, maybe related to the low middle income status of our country, where many people are the low income, low education status, and they are more destroyed by illness. And when there is so much of weakness on one side, we clinicians hold all the power given to us from our with our white coats, the stethoscopes, and the whole hospital things, and more than everything, protocols, which seem to be the god today. So the difference in power, I wonder, makes us a bit more arrogant than I would expect in a high income country. Maybe I am biased, but this arrogance is something that we'll have to shed if we are to have a good relationship with patients and families. If you once you shed this, you learn to sit down with somebody and say, I see you are in pain. Would you like to tell me about it? Whereas, if you are affected by that self importance, you have a greater muscle tone, you don't smile, your voice becomes a particularly affected thing, and you say, you have pain, tell me about it. And that will not bring out the real person. So, moreover, being aware of our own limitations, after all, we are not God Almighty. This makes us more open to others' perspective. It promotes mutual respect, enables teamwork, and particularly to make a connection with patients. This humility is very important. Uh, and the word love is not often used in clinical medicine. Dr. Christopher Booth, when from Queen's University in Canada, an oncologist, went with our team on home visits. So he had to work through a translator. He asked a patient with advanced cancer what the person valued most about the visits. Chris writes, his response captured the essence of humanism in cancer care. He stated simply, first of all, I feel very loved. Now, a few minutes back on the chat box, Dr. Asha Deshmukh asked a question about how much would all this be relevant to somebody on in the ICU, where you have to decide whether to continue the non-invasive ventilation or intubate. I mean, not exactly that question, but that's seemed to be the uh, gist of it. And essentially, the thing that struck me most in the question was there can be situations where you really cannot employ the questionnaire. It may be too late. All this should have started early. But even at the last minute, if the person is conscious, or is there a vestige of consciousness in that person, they may still respond, and a touch and a kind word and a bit of love would still be valuable. Maybe at that time, conveying love is very important, and the person at least feels cared for, and that is some small level of spiritual upliftment. So, uh, the next point they want to bring up is respect, which is possibly related to humility also. Uh, this person, totally helpless, abandoned by family, not usual in our culture, but it happens sometimes, and in a broken home that's not her own, lying there. And I wonder what all struggles have she gone through in her life. Will I have at least 1/10 of her courage, of her ability to overcome obstacles? I'm sure I wouldn't. And just be having that awareness allows me to think of her as a being that is superior to me in some ways. And that helps me to treat that person with respect, even when I am burdened by my white coat and the doctor's uh, uniform. Another thing that's often forgotten here, this I'm sorry, I'm not sure that this is from your book. I thought I should add it. Be engaged with the community. Even without that, confidentiality is not ordinarily kept religiously. Well, our society is also a bit more open, and uh, individuals' autonomy is less. We'll come to that again. So, whatever is visible about me is common knowledge. But if we do not assure them of confidentiality, they will not be able to open up really. This will have to be mentioned well in advance in our culture, especially when we engage with the community and there are so many people involved in care. Some relationships will still have to be confidential. And yet another important point that I wanted to bring about in the Indian, well, not only Indian context, I would say the global South context. The, the compared to the global North, hey, which is only 15% of the global population. 85% of the global population is the global South. There are many things that the global South doesn't have. The list would be long, including money, food, everything, education. But there is some strength that is a better family structure. Oh, we are also getting civilized and the family structure is falling apart. There is a visible change, but by and large, there is a family structure and family support, which is a huge wealth that we have and we don't recognize. But there is also some downside to it. The concept of normative ethics or ethical relativism says that what is valuable, good, or right is determined by society. Everything that is in a Western textbook of ethics may not be acceptable to people. And if it is not acceptable to people, what's the use? So, if we go by normative ethics, uh, in the global north, the individual's autonomy is paramount. This would be my life. Nobody else has more right over this body than myself. In the global south context, that may not apply to the same way. Oh, I recognize that that's important. I recognize that this man, for whom, on the picture, for whom the decisions are taken away by the healthier, younger relatives, he is looking pathetic. I know that he should have his rights, but the reality is, as a negative fallout of the family structure, perhaps, the collective autonomy of the family and even the neighbor would make conflict with the individual autonomy unless we recognize this and we go accordingly. We are lost. We, if I was told by one of the people who taught me more than half a century back from the UK, so they said people ask, "Oh, don't tell my husband, he cannot take it." And the doctor's response would be, well, if he asks me, I can't tell him a lie, can I? Can I? And that's an acceptable answer to the family. Seemed to be. But here, of course, it's a white lie. You must tell him that he's going to be okay. That would be their response. So, where does that leave us? When collective autonomy is a reality in front of us, whatever some textbooks say, how do we tackle the issue? The only way to tackle is, I feel, a shared decision making. a partnership between the patient and the family with the doctor. I suppose that would apply to the West also. I am sure many people would be following that. But here, that family's involvement makes it complicated because it's not one person. You have to talk to several people. And then comes the daughter from Dubai or the son from New York. You have to start all over again. But there is no way of escaping this. We have to accept collective autonomy as a fact of life in the global south and act accordingly. And finally, I would point out the relevance of weak paternalism. A more westernized approach that I see among doctors who have returned from the Western countries, particularly excellent doctors, uh, they give options. You can have this chemotherapy, which will be 15,000 rupees, or and that gives dash percentage of results, or you can have this for 1.5 lakhs. The person doesn't know what to do. A would mean he may be able to borrow 15,000 rupees and do it. B would mean that he will have to sell his house. But what should he do? He doesn't know. And he says, I don't know what to do, doctor. I'll tell you, I'll do what you ask me to do. What should I do? Well, the doctor, I have repeatedly seen the answer being given. I can't take that decision. It's your life, you will have to decide. Well, what I believe we should be doing is sit down with him, find out the implications, and maybe a little bit of weak paternalism will be much kinder. You know, if I were in your position, I think I would go for the 15,000 thing. After all, it also has a result. That's not too bad. Maybe we'll have to accept that. I am prepared to practice that weak paternalism. I know everybody will not agree with me, but just leaving them dumbfounded and without that answer will mean that he will get advice from uneducated, he'll get uneducated advice from somebody and act. So, particularly in the last point, I am giving a personal opinion open for discussion. So, the important points that I talked about were the value of humility to build relationships, the importance of love, again to build relationships, and to be human, importance of respect, considering, remembering that everybody else is superior to myself in some way, the reminder about confidentiality, which in India we seem to forget so too often, the importance of collective autonomy of family, and therefore shared decision making, taking time, sometimes frustrating, but that's so vitally important. And I gave a personal opinion that we should be practicing weak paternalism when the person expresses helplessness and pleads, Doctor, you tell me what to do, I'll follow your advice. So, friends, thank you very much. I started a bit late, so I hope I have stuck to time. Thank you.
Thank you, sir, for those practical points, which I'm sure many of who are in India and in neighboring countries are facing. Um, so now I think first we will have a few reflections from the participants, and then we will take a few questions. So, Mahesh, are you there? Uh, Mahesh, can you allow Dr. Pankaj Chowdhury to come in?
Yeah, yeah.
Dr. Pankaj Chowdhury, please restrict yourself to maximum of 3 minutes, and please share one of your reflection.
Before Pankaj comes in, Sunil, just one question.
Yeah.
Was I audible for the last 15 minutes?
Yeah, yeah.
Okay,
Very
thank you.
clear.
Yes, Pankaj, please go ahead.
Dr. Pankaj, please unmute yourself.
Yes. Audible? Am I audible?
Yeah, please speak.
Dr. Sunil, am I audible?
Yeah, yeah,
Yeah.
I'm audible.
yeah.
Yes, yes, please go.
Okay. So, first of all, I would like to thank Dr. Harvey and Dr. Rajagopal for navigating my boat to the last two sessions abroad in India, global north and global south today. So, the patient I'd like to share about is was a gentleman. I think I'm resonating a lot. Is it resonating?
And I think it's okay.
Okay. So this man was an elderly person in his 70s, and on a wheelchair, he was wheeled in for pain relief. He could not open his mouth because he had severe trismus. He had tracheostomy recently, and he had spent the last maybe 3, 4 years in the disease and but study for last 2 years. Very well educated family. They knew all about everything else. Only the pain could not be managed. So my ENT surgeon said to you please go to the palliative people. After the thing, his wife and daughter-in-law had come on the first visit. So in a OPD, after the interaction of maybe 5 or 10 minutes or maybe 20 minutes, he suddenly had a mobile and he just pointed it to me. He just gave me his mobile. I thought probably he cannot speak, so he has written down because I tell people if you can't say, you can write down and bring in your next visit. But he said, that is me. And I was a little bit shocked to see a young, handsome man who's from Sikkim, mustachio and with a hat. And here this man was frail looking with a raised tube tracheostomy. Of course, that first visit was, I'm not a psychiatrist, sir, with due respect to all the people here. I'm just an oncologist, it's a little bit of palliative work now. So I prescribed the morphine and all, and they went away. Then the next time when the wife and the daughter-in-law came, and then subsequently the son, he said, no, no, my father was a very prominent person in Sikkim. He was a social worker and a minister in the government. I said, my goodness. So I suggested, why don't you move him back to his hometown? And that got the cat among the pigeons. I think about 2 or 3 weeks later, this man was terminally ill. He called up all excited, the son. Oh, what a miracle. My father is all chirping away. He's writing articles, mails. Half of Sikkim is coming to visit him. Now, Dr. Harvey, sorry, I didn't know anything about dignity therapy. We kind of learned it in palliation from Dr. Raja Gopal and all of the other teachers as goal setting. So I kind of gave the family a kind of goal. Uh, and then, because he was not open to discussion much initially. So this man was gardening and all. And the next maybe 6, 8 weeks, morphine dose went down. Everything went down. And I don't know subsequently what happened. But this was a real experience. And listening to Dr. Harvey's beauty therapy, and now Dr. Rajagopal, sir, your weak paternalism, I've been practicing in oncology for the last 30 years because taking the village, there's no other way to do it. We do not have many educated people. So they call us gods or whatever goddesses. And that is the way we withholded and stole them. See, if I was in your position, I would have done this. This is one of the lines. So I thought this is something which I have had an experience, and I thought it might be worth sharing with everybody here.
Thank you, Dr. Pankaj. Dr. Harvey or Rajabal, sir, do you have any comments?
Um, well, thank you
Sir,
for
you are on
sharing.
mute. Rajabal, sir, on mute.
Can you hear me?
Please unmute.
Sunil, somehow Pankaj's voice had a lot of echo as I
Yeah.
could hear it. Can you condense the question for me because I can hear you very clearly?
And no, I was asking whether you have any comments on the story that he
No,
has
no.
shared. He shared the story of a patient who had malignancy with tracheostomy, Rayleigh tube, and he was very frail. But then, when he went for rounds, he showed a photo in the mobile because he was unable to speak because of Christmas. And that was a young, handsome, beautiful person. And his son further added that he was the minister in Sikkim or some place. And then Dr. Pankaj asked them to take him to his hometown, and then he enjoyed the last 8 months with his wife on morphine also.
Can you hear me?
Sorry.
Yes, yes.
Yes.
Yes. So first off, thank you for the case. It's a wonderful case, and it illustrates so many of the principles that we've been talking about today and last week. I didn't speak about this, but I remember years back when I trained at Memorial Sloan Kettering in New York City. And I think I've written about this case. I walked into the room of a young man, and he didn't point his cell phone to me, but he had a photograph of himself on the nightstand in the hospital. And this was a man with a primary brain tumor. He had maybe weeks to live. You know, you can just sort of imagine the scene that I saw. But the picture, the photograph, was a picture of a young man who was a bodybuilder, and the contrast was extraordinary. Uh, at the time, I mean, I didn't have the experience, and I hadn't done the work that I've done over the years to have a deep appreciation as I do now as to what was happening in that moment. But it changes, as it did for you, when he showed you the picture. It changes your perception. You know, you suddenly are seeing him as more than a man with these various different physical and very difficult challenges as a result of his illness. You're seeing him in a way that includes personhood, I would say. Um, the other thing is that your intervention was beautiful because you suggested, well, why don't you take him home? And the thing about going home was he was affirmed. He was seen by his family and by his community, not as an old man who is now near end of life, but as a man who is a writer, who is a former politician, who is an activist. And so it allowed him to live out those 8 months in a way dramatically different than had you not done that, because it allowed him to feel that he lived until he died. He didn't spend his final months waiting for death. He lived until he died. That is extraordinary palliative care. And for that, my hat's off to you.
Thank you. Very
Thank
early in
you.
my training, I had seen a slide of Dr. Raja Gopal, who wrote the word listen on his OPD when he came back from Britain. Listen. And that's all I think is what I'm trying to do. Thank you very much for having me.
Thank you,
Thank
Pankaj.
you, Dr. Pankaj. Mahesh, now I would request Dr. Asha Deshmukh to please allow her to come to stage.
And later, Sunil, Dr. Nandini Shukla also has asked a very relevant question.
Yeah, Dr. Asha, please unmute and speak. Krishna, please unmute Dr. Asha Deshmukh. Krishna,
So we are not able to unmute. Let us go.
Dr. Asha. Are you able to, or otherwise, I think we will call Dr. Biju Raghavan. Can you allow Dr. Biju Raghavan to enter?
Yes, 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 yes. Invitation has been sent to Dr.
So, in the meantime, I think we would take a question, Dr. Harvey. How could we do dignity therapy for patients with progressive supranuclear palsy if their caregivers assist in their story? Probably not so impactful as their own record, but could it also help? It is by
Very
Dr.
good.
Nandini Shukla.
Very good. Can you hear me if I'm using this headphone?
Yeah,
Very
yeah,
well,
it's okay.
very well.
Good. Okay, because I was having trouble hearing the other speaker, so I thought I would use the headphone. So, wonderful question. Um, Although dignity therapy has been used perhaps more in patients with malignant illness, um, there's extensive experience about applying dignity therapy to people who are dying of non-malignant illness. So end-stage organ disease, neurodegenerative conditions, including ALS. You mentioned supranuclear palsy. The the issues then are, how do you facilitate dignity therapy taking place in a way that is going to accommodate that particular patient? Certainly, having family members involved can be very helpful. Um, We've also had instances, I remember cases of people with ALS that we had involved in doing dignity therapy in our trials. And what we ended up doing is giving them sending them the electronic version, the digital version of the transcribed document, and then having them use keyboard skills or facilitated skills so that they could um, uh, manipulate that document so that they could then develop a full dignity therapy intervention. What I again would come back to is this. Um, the protocol needs to accommodate the patient needs. Sometimes that means having a third party involved, like having a family member there. I remember, for example, I remember doing dignity therapy during COVID with an older woman. You know, she was quite frail. She was in a personal care home. Of course, because of public health restrictions, I couldn't visit her, but she had a healthcare aide with her throughout. And what that person did is they set up the technology. They made sure that the all the technology was working so that she could access dignity therapy. So my fallback is, look at what the patient needs. If that patient with supranuclear palsy that you're thinking about needs assistance that could be provided by a family member, there is no harm, and in fact there's good in having that family member there, because they will facilitate the creation of the document. The one last thing, and maybe we hadn't talked about it, is that there are, ideally, I mean, I like to see patients individually. There are patients who feel more comfortable having a family member there, and we always accommodate that. The only caution, and you find this anytime you have a family member involved in an interview that you're doing with the patient, is you want to make sure that the family member doesn't take over, doesn't kind of hijack the process, so to speak. When it's working well, though, usually, especially if somebody is relatively fragile or frail, having the family member there can not only give them confidence, but sometimes can help facilitate disclosures. So I remember a gentleman that we saw in his apartment years ago who was really quite frail, quite fragile. And occasionally, we would ask a question and he would, I'm really not sure. And the wife would say, "Well, dear, don't you remember when?" And then he would kind of say, "Oh, yes." And he would start to talk about that. So, in that way, the presence of the family member can help create a co construction. So, getting back to people with neurodegenerative conditions, look at ways in which families or an other third party can be present to help facilitate. And can it be effective or as effective? In my experience, absolutely. It can be as effective, but it means making the accommodations.
Thank you, Dr. Harvey. Um, uh, Biju, I think you can talk now, and then Dr. Asha.
Dr. Harvey, thank you for the treat these past two sessions have been.
Oh, my
Thank you
pleasure.
for your time, energy, and effort. And I would like to echo what Dr. Rajagopal sir said. Are you for real?
I'll pinch myself. I think so.
Thank you for being there. Me and Sunil were trained under Dr. Rajagopal sir, and we are constantly striving to be worthy of his time, energy, and effort on us. I
Wonderful
remember
role
one
model.
incident. I remember one incident way back in 2004 when I was doing my post graduation along with Sunil. I saw one patient who was just being brought into the inpatient bed, and I had the stent around my neck, and he was terminally ill, being brought in to be taken care of. And because I had this death, he recognized me as a doctor, and he said the first and words from his mouth were, "Doctor, don't allow that woman to come anywhere near me till I die." And that woman was his wife, who stood outside the room in the corridor, crying her heart out with her hands, with her face
Oh,
covered by her hands.
oh
And to
my
cut the
goodness.
story short, this loving, beautiful wife used to force feed him because he was anorexic cachectic because of an advanced malignancy. And he suffered and suffered. And in the end, the relationship broke down. And
Mm,
he kind of cursed her before she died. So that made a big impression on my head because it happened right in front of my eyes. Those were early
mm,
days. I didn't know what to do, how to respond. But over the years, 22 years now, I have kind of developed kind of a protocol of talking to the family in ensuring the patient's dignity is not hurt. When they are terminally ill, the power balance shifts from the patient to the family, and the family, with all good intentions in trying to get the patient better, misguided. Nobody has counseled them enough. One of the weapons in their hand is food, and they try to shove it down the patient's body, hoping that things will improve. And as a result, the patient suffers physically, emotionally, relationships breaks down. And I kind of counsel them and tell them that let them have food for comfort, but it will not improve the appetite, and not to force feed them. So,
absolutely.
uh, and this, once they realize that what they have been doing, many of times they change their behavior, and in that sense, we are able to protect the dignity of life of that patient. I just tell them two things: that if somebody is helpless, if you force things on them that they don't want, their dignity suffers. And if you deny them what they want, maybe they want a little bit of alcohol which they have had for a long time, or maybe they want to smoke, and I tell them, if they want it, give them. We should
Yep,
teach not to drink and not to smoke to school children, not somebody lying on their deathbed. So these are
absolutely.
some. There are many other things, other ways where we try to restore dignity of our patients, especially those who are terminally ill. But I understand we have very limited time, so I'll just stop over here. Thank you for your time again, and thank you, Rajagopal sir, for your work on us. We are just a product of your hard work.
Mm. Well, thank you for sharing that case. It's uh, wonderful and poignant to hear how you were involved and how you try to kind of navigate what was a very difficult space. I mean, as you point out, for people, food, offering food, giving food is an expression of love. And to deny that feels like they're withholding love. And the things that patients and particularly family members need to come to appreciate is it's not that they no longer need your love. It just needs to be expressed in a way that they can accept. And so that would be the sort of important negotiation that would take place with that gentleman who's saying, don't let that woman come near to me. Say, well, help me understand what that's about. What's going on. I remember a case, and this was just last year. It was There were similarities. It was a wife who was dying, and she and her husband were not getting along well. I mean, there'd been a long history prior to that of them not getting along well, but he was heartbroken because she didn't even want him to come to the hospital. And we were able to work through with the social worker, talking with him, talking with her, eventually to be able to get them in the same room together. Now, it's not that there were these declarations of love that life is not Hollywood. It doesn't end with this lovely bow that everything is neat and tidy. But they could at least say, we both tried our best. We both did what we could, and he was there in the room. And I remember talking to him afterwards, and have since kept contact with him. It changed his grief in a profound way. It wasn't His last memory wasn't standing outside of the hospital thinking, "Oh my God, how terrible. We were estranged, and this is how it ended." His last memories were, you know, I was there in the room. We kind of expressed the things that we did appreciate about each other, and what a difference that has made for him and his three children. So thank you for sharing that. What it points out is that it's easy to write about things in a very kind of simplistic way, in a kind of very neat way. Life isn't simplistic. Life isn't neat. It's messy, and the real work comes when we kind of delve into the messiness and try and understand it in a way that can serve our patients and families. So thank you.
Thank you, Biju and Dr. Savi. Um, Now I think Dr. Asha, you can share your reflection.
Everyone, am I audible?
Yes, yes.
Yes. Thank you, Dr. Harvey, for the very enjoyable session, the first one and this one too. So I would just like to share quickly. I don't work in an onco setup. I work in a non-oncology setup. So a couple of months ago, there was this patient who was a 38-year-old gold medalist scientist. So he was this chemistry scientist, but he had a MI, and he was posted for a CABG surgery, for a bypass surgery, and he didn't know what to do. He was anxious. He couldn't sleep. So I went up to him and I actually humored him. So his wife told me that after many months he laughed. So that I thought was something that was good for him. And I never once spoke about his disease or why he landed up in this situation. I didn't advise him because I think he had had enough of that already. We just spoke of things that were not the disease, the things that he identified with. And I think that really helped because she later on told me after many months he had a good night's sleep. So that I thought was brilliant, that I could help him in some way. And I also honestly believe that when we as doctors can stop seeing numbers and lab results as results of success when we treat a patient, that is when we have truly arrived. When we can truly call ourselves doctors is when we don't equate a lab result or a number as a success as being a doctor. We need to see the patient as more than just a patient with a disease, because I honestly believe that whenever someone has a disease, this is what I tell them, that you have the disease inside of you, so you are bigger than the disease. So you have that bandwidth to overcome the disease at any time. So this is what I want to tell everyone, that when you enter the room, be on the same level as the patient, sit down with the patient. That kind of eases most of the tension in the room, and then he starts speaking. So that's my thing. And I am not many years old into this noble field of pal care. I'm just a year old, but I think palliative care found me. That's all I can say. Yeah.
Well, and the profession is fortunate that it found you, Asha. Again, there's much that could be said, but I mean the essence of your approach and in your intervention really speaks to what I've tried to talk about today and 2 days ago, the fact that part of being a healthcare provider, part of being a healer, as you say, is it's not just dealing with the numbers, it's not just dealing with the physiology or pathophysiology, it's dealing with and acknowledging whole persons. That article that I cited last couple of days ago titled "Patients are people with feelings that matter." Therefore, if we're going to be dealing with patients, we need to be mindful that they are people and their feelings matter. And when you came in and you spoke about him, not about his illness, you spoke about him. Um, he felt seen. And last time when we talked about intensive caring, I mean, really some of the essence of intensive caring is finding ways of making sure people feel seen, because that's how people will feel that indeed they do matter. Um, and maybe in closing, I'll say, it reminds me of what I said to the medical students when I spoke to them last year at the white coat ceremony. Patients won't care what you know until they know that you care.
Yes, I agree.
Thank you.
Thank you. Thank you.
Thank you, Dr. Asha
Pleasure.
and Harvey. So I think time is already 8:35, but I think I will take 5 minutes more, considering this is the last session, if it is okay for you, Harvey.
Yep.
Okay. So, Dr. Sangana, Dr. Sangana, are you able?
Yes,
Yeah,
yes.
you can quickly share your story.
Namaste, everyone. Respected Dr. Harvey, Dr. Rajagopal, and all esteemed participants here. So it has been extremely inspiring, and every word that you have spoken, Dr. Harvey, Dr. Rajagopal, I have made notes so that as an upcoming physician in this field of integrative oncology, I'm able to internalize. You began on first, I'll be very brief. So you began with the points that patients are people with feelings that matter, and your article on ABCD, dignity in care approach consistent with the thread, non-judgmental affirmation, dignity therapy as a concept, how can a physician or I can be a fragrance of care, elements of presence, being fully present, non distracted. Time is lovely only when it is available. How do we take care that we are fully present? Our tone of talking, and a very important concept that you spoke about, that people can model how to die. Your speech about white coat ceremony and moving from patienthood to personhood and dignity questionnaire. So I am a trained Ayurveda physician and Indian system of medicine. The premise is all about whole person care, but I do feel that palliative care or end of life care and talking about dignity, while it comes so inherently to Ayurveda, but it is not being formally spoken with Ayurveda physicians. I do feel that this topic, and as Pallium India and you brought it out, it could become a point of a translational and an interconnectedness, especially in country like India, where there are so many Ayurveda physicians coming out. And maybe this workforce can together contribute towards this very beautiful concept. And I had an opportunity to meet Dr. Rajagopal last year at NIMHANS. If I think he'll be able to recollect. With the founder, Mr. Rajiv Vasudevan. So I'm very much looking forward that I become an instrument to bring Indian system of medicine in forefront in the concept of integrative oncology. And thank you, Dr. Harvey, everybody here for giving me an opportunity to share my thoughts.
Thank you,
No.
Dr. Sangana. And good to know that this is going to hand it over to many more physicians and colleagues of your own.
Yes.
I think now I will move on to Dr. Yadav. Dr. Yadav?
Yes. Can you hear
Yeah.
me?
Yes, yes.
Yes, thank you, Dr. Harvey, for the two wonderful sessions. Actually, I am here in the palliative field just because of Dr. Rajagopal sir. And I would like to share a few one or two experiences. Sometime back, I had a patient who was having a colostomy. One day he told me he doesn't want to leave at all because nobody comes here, even his wife. Because he has lost all his dignity and he doesn't feel like leaving. He doesn't being a, like feel he doesn't feel like being a man. So that time I thought what we can do for him. That time we heard about we know say something else called colostomy irrigation. We taught him colostomy irrigation, and he told. Then next week he came and told us. Now he feels like leaving because he has some control over the thing. The control over the thing. That I have some kind of dignity back. And after that, whenever we have a patient with a catheter, when we discuss with them, they say that somebody is including their nudity every 28 days to put a new catheter. So when we offered them silicone catheter and later nalatin catheter, they felt like they are in control. So when they are in control, they get some dignity back. From the beginning of our palliative OP itself, we introduced dignity. We made sure that dignity is or respect to the person is standardized and made at the implemented in the system level. Because we made sure that the patient is not made to wait, not made to go for medicines. They were not at all even called cases. They are not even called patients, because whenever we call them a patient, we felt that as Rajagopal sir says, they are persons with suffering. So why can't we term them as guests? So we consider every person as guest. So we are treating them as with dignity. And one of the most interesting thing we found out was when we tried to do the dignity therapy after reading your book and all without any having practical experience. Even with our experience in qualitative research, we found nobody willing to give consent, and they are not. They are very. They feel very awkward about this transcripts and all. So we did a 4 or 5 live review for patients, and those people told us about their achievements and lot of things. And another thing, we make sure that whenever we have patients, we call them guests, we get the whole history of them, about 40 pages with us. So we reconstruct their life and we imagine under 4 headings: physical, psychological, socio-economic, and spiritual, when they were normal and when they are now. We call them empathy visualization. Then we think from their being what they were 4 or 5 years back and now who they are. Then we come out of their body and imagine what we can do for them. Nowadays, for the last 3 months, we even have conducts a caregiver session for these imagination sessions. And many of our volunteers, many of our caregivers told us start weeping once they start this visualization exercise. And these are the things we are doing there. So one of the thing we failed. I think most of the things we actually failed in 100 when we try for 100% result and all. But the transcription and the getting consent is one of the most what do you call that, a difficult thing we had. Then another thing about this is we make it sure that whenever we solve an issue at a one level, this should not cause suffering to another dimensions. Like we have a patient, suppose, who needs a wheelchair, or we needs water air bed. Usually, this is usually given by some people in and around. They give some photo sessions and all. When we discuss with this particular person, they say that it is they are feeling like beggars. So nowadays we make sure that whenever we do something at a physical level, it should not cause what you call suffering in the psychological, social, and spiritual dimension. These are things we are trying to do, and what we found was, though we wanted to do some 100 things, we failed in 97%.
But I also understand that you are able to practice many things, which makes many difference to the patients and families. Thank you.
Harvey and everyone, Yadav's palliative care clinic is the only one that I have seen where every guest, mind you, guest is when the guest arrives, whoever is sitting there in the chair gets up from the chair, holds the hands, and welcomes the person.
Wonderful. Wonderful.
In one moment, dignity therapy all condensed into that.
Yes. I think and it goes to show we all have a great deal to learn from each other.
Thank you. I think, and Dr. Harvey, you are. I think we have to close the session, but
Yes.
a few words from you.
Um, I guess my overwhelming feeling is one of gratitude. I think I said at the very outset, I was hoping to be able to be provided a platform to share some of my ideas with colleagues as broadly and widely as possible in India. Approaching Pallium India, of course, was the right move. All of the work that you did has made this possible. Again, the Texas School of Mental Health, I know we're very active in helping as well to disseminate this, to advertise this. So my feeling walking away from this is one of gratitude, humility. Listening to all of the cases that you've shared tells me that you are all doing this work. You're all engaged in this work. Hopefully, what I've shared with you has given you some ideas and some language for you to continue to further this work. And again, please take the time to spread the word, make this known so that collectively we can all raise the bar on dignity and person-centered care. Thank you.
Thank you, Dr. Harvey. Rajabal sir.
No, my only thank you. Word of gratitude to Harvey and Sunil. There are several relevant questions pending. I see so many Dinesh, Gaurav, and others. So maybe we'll let us get all the questions together and address them over the email or WhatsApp or whatever you do.
Perfect. No, happy to do that.
With apologies to everyone whose question couldn't be taken up now.
Yes, so I'm also sorry that some of you could not get a chance to speak. We are already, it's 8:45 and I don't think it's a good idea to extend the session now. So we have to consider everybody's time as precious. So thank you, Dr. Harvey Chochinov, for these two wonderful sessions and making us feel that we are also human beings and it is not only the medicines that we are going to practice, there are some human side of it.
Beautiful.
Thank you. Thank you.
Thank you.
And I hope to see you very soon for another session. Thank you, Rajamal sir. And thank you, everybody who has come here for the two sessions. And I hope all of you would have enjoyed all these two sessions and the stories by our participants. And I hope we have learned from each other also. So thank you, everybody. And it's over to Gayatri.
Bye-bye.
As we come to the end of this enlightening today webinar session on dignity in care, I would like to extend my heartfelt gratitude to our distinguished speakers, Dr. Harvey Max Chochinov and Dr. M.R. Rajagopal sir, for sharing their invaluable insights and expertise with us. And very special thank you to all participants for your active participation, thoughtful questions, and engagement. As we move forward, let us take these learnings into our daily work. Thank you once again for being part of this wonderful journey. Wishing you all the best in your continued efforts to make healthcare more humane. Stay inspired, take care, and goodbye.
Thank you.
Bye.
Good night and good day, Harvey.
Thank
Good
you.
day.
Good night,
Bye.
everybody.
Bye.